Good evening, everyone. I am Dr. Ravi Teja. I am infectious diseases physician. Today, we will discuss about one important disease, that is enteric fever. It is also called typhoid fever. So, this is very commonly seen in all practice, both pediatricians and physicians. So, today I will discuss this important disease. Yes, introduction. Enteric fever. It is also called typhoid fever. So, what are the serotypes causing this enteric fever? So, there are predominantly two serotypes. One is Salmonella typhi, other one is Salmonella paratyphi. So, this typhi and paratyphi are the two serotypes which cause enteric fever. Salmonella is the genus, and typhi and paratyphi are not species. There are serotypes. And this Salmonella typhi and paratyphi is restricted to human host in whom these organisms cause enteric fever. So enteric fever is caused by either Salmonella typhi or Salmonella paratyphi. There are many remaining serotypes like non-typhoidal salmonellosis. Apart from these two serotypes, other serotypes are called non-typhoidal salmonella or NTS. They also cause disease in humans, but not enteric fever. So there are about 200 serotypes of Salmonella which are pathogenic to humans, in whom they often cause gastroenteritis and can be associated with localized infections or very rarely bacteremia. So among all the 200 serotypes, all can affect humans, and they can also affect other mammals and reptiles also. But these two serotypes, Salmonella typhi and Salmonella paratyphi, are exclusively affect only humans. Just remember that. Next, Salmonella are gram-negative, non-spore forming and facultatively anaerobic bacilli. And you must have heard about these three antigens which they have. So this serotyping is based on antigenically diverse surface structures. One is the somatic O antigen, which is a cell wall component, lipopolysaccharide cell wall component, and the surface VA antigen and the flagellar H antigen. So these three antigens will be there on the bacterium. So coming to the pathogenesis, so how will one acquire enteric fever or typhoid fever? It is due to ingestion of organisms from contaminated food and water. So this food and water will be fecally contaminated by any ill person having diarrhea or any asymptomatic person having diarrhea. So when those persons pass diarrhea, it will be infected the water and food, and whenever the normal person consumes those contaminated food and water with bacteria, he will get ingested of the bacteria and he will get the disease. So ingested dose is an important determinant of incubation period and disease severity. So the number of bacteria will determine the incubation period and disease severity. The less bacteria you ingest, the period will be prolonged and disease severity will be less. If you ingest huge colony forming units of bacteria, you will have incubation period will be less and disease severity will be more. And conditions that decrease either stomach acidity or intestinal integrity. When our intestinal integrity is disrupted or our stomach acidity is less, we are prone to the bacteria is prone to migrate to the intestinal walls or stomach walls and cause disease. So stomach acidity, if age is less than 1 year, or patients or adults who are taking acid suppressive therapy or echlorohydric disease or having echlorohydric disease, their stomach acidity will be less and they will not be able to kill the bacteria in the stomach. So the bacteria will pass into the small intestine. or if they have intestinal problem, like intestinal integrity is less, like any inflammatory bowel disease, or who are on cytotoxic chemotherapy, or who underwent some prior GI surgery, or alteration of the intestinal microbiome by antibiotic administration, will lose the integrity of the intestine, and the bacteria can easily migrate through the small intestine into the blood. And once this Salmonella typhi and Paratyphi reach the small intestine, when the stomach acidity is less, when the stomach acid cannot kill the bacteria, it will pass into the small intestine, and they penetrate the mucus layer of the gut and traverse the intestinal layer to the phagocytic cells, that is a microfold M cells that reside in the Peyer's patches. So they reach the small intestine, they invade the Peyer's patches. So after causing the epithelial layer of small intestine, the typhi and paratyphi, which cause enteric fever, are phagocytosed by macrophages. So once the phagocytosis is done, this typhoidal salmonella disseminate throughout the body in macrophages via the lymphatics and colonize the reticuloendothelial tissues like liver, spleen, lymph nodes, and bone marrow. So they will first come to the small intestine. Because of poor acid, the bacteria will not be killed, or huge volume of bacteria which could not be killed by the acid, they come to small intestine and they invade the Peyer's patches, and the local macrophages will invade the phagocytose the bacteria, and the macrophages will carry the bacteria into various reticuloendothelial organs like liver, spleen, lymph nodes, and bone marrow. From there to the blood. So patients initially have relatively few or no signs and symptoms during this initial incubation period. In contrast to enteric fever, which is characterized by infiltration of mononuclear cells into small bowel mucosa, the non-typhoidal salmonella has neutrophilic infiltration into both large bowel and small bowel. So non-typhoidal salmonella generally causes gastroenteritis, but not salmonella. Salmonella also causes gastroenteritis, but NTS is more common, causing inflammatory diarrhea. So few things about important microbiology. So there are emerging MDR and XDR strains of Salmonella. So what is the MDR Salmonella? So strains which are resistant to ampicillin, chloramphenicol, and cotrimoxazole. And these three antibiotics are resistant. It is called MDR strain. And what is the XDR strain? XDR strain, along with these three, ampicillin, chloramphenicol, cotrimoxazole, if the strain is also resistant to ceftriaxone and fluoroquinolones, all the five antibiotics are resistant, it is called XDR salmonella. So this first emerged in 2016 in urban slums of Sindh province in southeastern Pakistan, and extensively drug resistant XDR Salmonella typhi, the H58 clone with plasmid mediated ESBL resistance, has now become the dominant cause of typhoid fever in Pakistan. So this XDR strain is resistant to all the ampicillin, chloramphenicol, cotrimoxazole, ceftriaxone, and fluoroquinolones. And we have very few choices of antibiotics left for treating this XDR Salmonella. Next, improvements in food handling and water and sewage treatment will help in reducing the incidence of disease. So anywhere when you see high incidence of enteric fever, it implies that the food and water are contaminated with human sewage. So whenever human sewage gets mixed with water or food in the farms, then eating those vegetables or fruits without washing and drinking those contaminated water leads to enteric fever. More seen in poor neighborhoods in larger cities than in rural areas, because poor neighborhoods in cities will not have good water and sewage supply. And what are the risk factors? So as you know, it is a food and waterborne illness. So contaminated food, contaminated drinking water, not only water, contaminated ice, contaminated drinking water, contaminated ice, any flooding in any area, or food and water drinks purchased from street vendors who have not used uh, bottled water or sterile water, can be contaminated and cause disease. and raw fruits and vegetables grown in fields fertilized with sewage. There is some practice in very areas where wastewater is being used for growing vegetables and fruits. So consuming those, if there is infection is there, it can cause disease. Ill household contacts. Any person in house having severe diarrhea with typhoid, he can spread to other people if proper hand hygiene is not followed, and lack of hand washing and toilet access. These are all the risk factors for acquiring the bacteria, which will lead to disease. Clinical course. So a high index of suspicion for this potentially fatal systemic illness is necessary when a person presents with fever for more than 48 hours. Generally, this enteric fever, the patient or the child comes with fever for more than 48 hours. So the incubation period is 10 to 14 days with a mean of 5 to 21 days. So remember this, the most prominent symptom is prolonged fever with 101 to 104 degrees Fahrenheit, which can continue up to 4 weeks if untreated. So prolonged fever will be there, 4 days, 5 days of fever, not resolving. So generally, you see any viral fever will resolve in 2-3 days. So, but this enteric fever, the fever lasting for more than 3 days, 4 days, no clear localization, we have to suspect enteric fever. And if that fever is not identified properly and treated, it can also lead to fever for 4 weeks. So other symptoms include headache, chills, myalgias, malaise, arthralgia, cough, and sweating are also seen. And GI symptoms like anorexia, abdominal pain, diarrhea is seen in around 50 to 78%, and constipation in around 30%, along with nausea and vomiting. So these are all symptoms. Most commonly, we see chills, headache, malaise, and myalgias. So along with fever, the four symptoms of headache, chills, myalgias, and malaise is commonly seen. Next, what are the physical findings? So hepatosplenomegaly or isolated splenomegaly can also be found, and this is a term called relative bradycardia at the peak of high fever is seen, and rose spots also seen, but in high pigment individuals, this is difficult to find. So what are rose spots? These are faint salmon colored blanching maculopapular rash located primarily on the trunk and chest, and these appear at the first week of illness. So 30% of patients at the end of first week, they will develop these rose spots, and they resolve spontaneously within 2 to 5 days. Complications. So at times it can lead to GI bleeding and intestinal perforation, as this salmonella bacteria invades the Peyer's patches, leads to enlargement, and if not identified and treated early, it can lead to intestinal perforation or GI bleed. Most commonly occur in 3rd to 4th week of illness and result from hyperplasia, ulceration, and necrosis of the ileocecal Peyer's patches at the initial site of salmonella infiltration. And other complications like neurologic manifestations also occur in 20 to 40% of patients and include meningitis, GB syndrome, neuritis, and neuropsychiatric symptoms. They're also seen, but rarely these are seen. And uncommon complications. So it is a systemic illness, so it can affect any organ. Just remember like that. It is systemic illness with blood bacteremia, so it can involve any organ. It can involve the meningitis. It can also cause pneumonia. It can affect the heart, causing pericarditis, myocarditis, endocarditis. It can involve the liver and spleen, causing abscesses. It can cause hematophagocytic syndrome. It can cause pancreatitis. It can cause HUS, arthritis, osteomyelitis, endophthalmitis, pancreatitis. So no organ is spared. But these are very uncommon and rare complications, not seen daily. So just remember the theory part, but whenever you don't find any etiology, you have to think in mind that whether it is enteric fever. So DIC, hemophagocytic syndrome, pancreatitis, hepatitis, hepatic and splenic abscesses and granulomas, endocarditis, pericarditis, myocarditis, orchitis, glomerulonephritis, pyelonephritis, and HUS, severe pneumonia, arthritis, osteomyelitis, endophthalmitis, and parotitis. So these are very uncommon complications. These used to be seen in prior era, some 20, 30 years before, where antibiotics are not available commonly. Now, extensive antibiotic use and early diagnosis, these complications are rarely seen. And 10% of patients develop mild relapse, usually within 2 to 3 weeks of fever resolution. So up to 10% of untreated patients with typhoid fever excrete salmonella in the feces or up to 3 months. And 2 to 5% develop chronic asymptomatic carriage, shedding the bacteria in either a urine stool for 1 year. So these asymptomatic patients who shed the bacteria in the urine or stool will cause contamination of food and water, and it leads to disease progression. And gallbladder is a site for chronic carriage. It's a very important point. Any patient with gallstones or abnormal gallbladder anatomy, if he develops salmonella bacteremia, so gallbladder can be a site of chronic carriage. And in high endemic countries like ours, chronic carriage is associated with an increased risk of GB cancer as well. It's a chronic complication. So what are the differential diagnoses for typhoid fever? So any patient or child coming with fever for more than 2 days, 3 days, and all non-specific symptoms like fever, headache, myalgias, malaise, arthralgias. So it can be any community-acquired infection like bacterial enteritis, dengue fever, viral hepatitis, rickettsial infections like scrub typhus. Also presents like this: fever for 3 4 days, some non-specific myalgias, arthralgia, malaise, leptospirosis. Also presents with fever, myalgias, malaise, amoebic liver abscess, fever, abdominal pain, acute HIV infection, also fever with no clear localization, and malaria fever with no clear localization. So there are all the differential diagnoses you have to keep in mind when you suspect enteric fever. So how will you confirm enteric fever? So other than a positive culture, that is most commonly blood culture, no specific lab test is diagnostic for enteric fever. Please remember, this is a very important point. Blood culture is a gold standard test which will confirm enteric fever. All other tests are not confirmatory. So what are the clues we have? Blood culture will take 48 to 72 hours to come. So what are the clues we have? So 15 to 25% of cases will have leukopenia and neutropenia, and eosinopenia is also important clue. CBC is easily available, so eosinopenia 0 to 1% is also clinical clue. And in first week of illness or 10 days of illness, children will also have leukocytosis. Leukopenia followed by leukocytosis. Most commonly, you'll see leukopenia, but in few children, leukocytosis is also seen. And there will be mild transaminitis. Moderately elevated values in left is also seen. And this blood culture is the most important test in diagnosis, so which sensitivity is up to 40 to 60% with good volume of blood being sent. If you send low volume, lower the volume of blood sent and lower is the sensitivity. And also if antibiotic exposure is there, the sensitivity of the blood culture will come down. So here's the most important point: no antibiotics before blood culture, and adequate volume of blood should be sent to diagnose enteric fever. So this is the recommended volume of blood for culture in pediatric patients. So any child more than or equal to 12.8 kilos, you can well send 10 ml, 10 ml of blood, that is 20 ml of blood. You can easily send in 2 pediatric bottles. So you'll have 1 pediatric bottle, you can send 10 ml of blood. You can take another pediatric bottle and send 10 ml of blood. So 10 ml, 10 ml, 20 ml of blood. good volume which will help us diagnose enteric fever. So any child more than 12.8 kilos, you can send 20 ml of blood. You should send 20 ml of blood to confirm the infection. And children between weight between 2.1 to 12.7 kilos, you can send 6 ml of blood. Take one pediatric bottle, take 6 ml of blood. So this is a practice of sending only 3 ml or 5 ml in child with 10 kilos. So child with 10 kilos, you should send 6 ml of blood. If you send 3 ml, already half the volume you have reduced. So the pickup rate of bacteria in the blood will be less, and you will be missing the diagnosis. Next, bone marrow culture is also more sensitive than blood culture, but it is not commonly done. So it's a theoretical topic. So, and its yield is not reduced by up to 5 days of per antibiotic therapy. Also, as I have said, antibiotic exposure prior will reduce the yield of blood culture, but bone marrow culture will still pick up the bacteria. And other rapid diagnostic tests are also commonly available, like typhi.igm, but its sensitivity is only 70 to 80% and specificity is only 80 to 90%. So if this test is negative, you can't completely rule out typhoid fever. Um, so thus, these rapid diagnostic tests are not sufficiently accurate to replace blood cultures as the main approach to diagnosis of enteric fever. So to rule out or rule in typhoid fever, always blood culture followed by typhi.igm if required. Just doing typhi.igm, and if it is negative, you can't say it is not typhoid fever. It still can be typhoid fever because the sensitivity and specificity of this typhi.igm is not 100%. Please remember that. Next, coming to Vidal test. So this Vidal test detects anti-Salmonella typhi antibodies. This assay is of limited clinical utility in endemic areas because of the positive results may represent previous infection. So these tests just detects antibodies to exposure. So in very high endemic country like ours, all of them will have some positive titers, some antibodies will be there. So just seeing one vital report, we cannot diagnose enteric fever. So when paired acute and convalescent samples are studied, a fourfold rise in titers will only help, but will not wait for 2 weeks for titers to raise. So and they're very non-specific. So we should never use Vidal test. This is a report of a patient, Salmonella typhi 1 is to 160 and Salmonella typhi H 1 is to 80. The single value will not help. They have reported as accreditation positive, but the single value will not help me diagnose typhoid fever because the patient must have had some Salmonella typhi exposure before, very low volume of colony forming units which have caused some antibody response, but this will not help me in diagnosing typhoid fever. So never diagnose typhoid fever on Vidal test. You will not wait for convalescent titers to raise for 2 weeks. So a single report will not be helpful. So don't do this Vidal test. Treatment. So coming to the treatment, because of the high prevalence of resistance to fluoroquinolones in India, they should no longer be used for empiric treatment. One of the studies from Chennai, we showed some 90% of resistance to fluoroquinolones. So it should not be, fluoroquinolones should not be used for empiric treatment. What are the other antibiotics available for treatment? We can use ceftriaxone or IV cefotaxime. A dose of ceftriaxone dose is 50 to 100 mg per kg per day, and cefotaxime is 150 to 200 mg per kg per day divided 6th hourly or 8th hourly. Or oral cefixime can be used, but the duration is 10 to 14 days. Most of them will you just take 5 days or 7 days of antibiotics, and the fever will temporarily come down, but disease will relapse again if not full course is followed. 10 to 14 days of cephalosporin should be given if confirmed. And trimethoprim sulfamethoxazole, a dose of 10 mg per kg per day of trimethoprim can also be used for enteric fever. Azithromycin can also be used, but a dose is at rate of 20 mg per kg per day. It will higher dose compared to normal azithromycin dose for 7 days. And therapy should be given for at least 10 days or 5 days after fever resolution. So as you can see, 10 to 14 days should be given. Azithromycin antibiotic has a very long half-life, so the duration for azithromycin is 7 days. Coming to prevention and control, the most important step is safe food and water consumption. This is the first important step which you can do to prevent acquiring enteric fever. And there are also vaccines available. Typhoid conjugate vaccines are available, which will help us to prevent the disease. Like type bar, TCV, typhi, BEV are available. A single intramuscular 0.5 ml of vaccine is safe, and it is 79 to 95% effective with antibody response persisting up to 7 years. So just it will help you in reducing the disease burden, but it will not completely prevent you from acquiring the disease. So this 5% still chance will be there if a vaccine you have taken some 10 years back, so and we have eaten or drank some contaminated food and water, still you can develop. But vaccines will definitely help in reducing the disease burden in the community and also for each individual. So what are the take home points in enteric fever? So high index of suspicion should be there. So any child coming with prolonged fever for more than 2 days, 3 days, you should keep in mind enteric fever. And recent travel, extensive travel and outside food, fever, extensive travel, you should keep in mind enteric fever. And always blood culture. So is a very important step in diagnosing. Once culture is positive, it will be very easy for you to get the sensitivity and give appropriate antibiotic. Otherwise, you have to give empiric antibiotics. And always send blood culture before antibiotics. So as I have told you before, already giving antibiotics will reduce the yield of blood culture. So there is a practice like taking over the counter antibiotics. The patients or the parents or will just take over the counter antibiotics and give to the child. So the bacterial load will come down, but it will not be cured. So always blood culture before antibiotics. And the volume of blood culture. So any child weighing more than or equal to 12.8 kgs, 20 ml of blood has to be sent, and child 2 to 12.7 kilos, 6 ml of blood should be sent. This is the most important step. And never ask for Vidal test or diagnose typhoid fever based on Vidal report. As I have said before, it will not help in our country because our country is a very high endemic for typhoid fever. Everyone will have some positive titers, so it will not help us in diagnosing typhoid fever. And safe food and water consumption. So this is the most important step which will help us prevent the disease. And use antibiotic therapy carefully. No fluoroquinolones because of high resistance in our country. It should be used only after confirming the culture, showing that it is sensitive. Cannot be used empirically. So these are the important take-home points in enteric fever. Thank you. And coming to the last, eh, take the vaccine whenever it is possible. All children should take the vaccine. It reduces the disease burden in our community. So these are the important take-home points. Thank you.
Recording stopped.